Hi, everybody. I am honored to introduce Dr. Nicholas Penning. He's a professor of family medicine and a luminary on obesity medicine. And he's going to talk about these GLP-1 agonists. These are Ozempic and Mounjaro, and they are medicines that are very effective for weight loss, but also show promise in the treatment of lipedema. So without further ado, I'm going to have Dr. Pennings take over.
All right. Well, thank you, Dr. Wright. And this is a very exciting time that we have medications that are really highly effective for the treatment of obesity and can potentially play a role in the treatment of lipedema. So what we're going to do is go through some slides that will talk about what the strengths and weaknesses of these medications are. And so we're going to be talking about the impact of lipedema. I am associate professor and chair of family medicine at the Campbell University School of Osteopathic Medicine. And this really has been a very important topic to me as I see many patients with this condition. And treatment of lipedema has been a very challenging but exciting opportunity. So just some things about obesity, lipedema, and physical activity. We see that in particular that obesity is affecting individuals throughout the country at an increasing rate, especially over the last 3 or 4 decades in particular. And we can see just from this graph that you're looking at severe obesity that women are more affected than men are. And that is true, especially in patients with lipedema. We can see obesity across the country has been getting worse. That we're seeing higher rates of obesity. And this is a projection into 2030 and expected that some areas of the country will reach obesity rates of 60%. So what role does physical activity play? Or more importantly, what role does physical inactivity play? And here we can see distributions of physical inactivity throughout the country and compare that or juxtapose that to incidence of obesity around the country. We can see that areas that have lowest levels of physical activity often have some of the highest incidence of obesity. And we look at the converse, where those that have increased physical activity, those who are meeting the recommended guidelines of a minimum of 150 minutes per week of physical activity, we can see the lighter colored states are where those goals are not being met by much of the population. And again, those are the areas where we're seeing obesity at the highest activities. So why are we seeing less physical activity? Well, we're very reliant on technology, automation, where we can mow our lawn with automated devices. We can walk our dogs with golf carts, and the dog can get exercise, but not us. And so those are kind of technologies which are taking advantage of making it much easier to do less activity. But as a result, that's going to burn fewer calories and contribute to challenges of obesity. Employment is more sedentary too, or more likely to have desk jobs. If we look at the turn of the century in 1900, 50% of the people were involved in agriculture, which was very labor intensive. Now it's 4%, and agriculture is not very labor intensive. So we combine that with more screen time, with an environment that's not conducive. If you I live in and work in a rural area, there's no sidewalks, and it's very dangerous to walk on the streets here. So getting physical activity can be really difficult. And then physical limitations also limit our ability to get physical activity, especially in patients with lipedema, with increasing knee and hip problems, and just the weight of the legs slowing you down, making it harder to engage in activity. So we see some benefits of physical activity that help the general population, but what about patients with lipedema? Well, physical activity has a limited effect on weight loss in patients with lipedema. It has a limited effect on weight loss in people in general, but people with lipedema do not usually see a significant change in weight associated with lipedema, although it is still very important for building muscle strength and maintaining muscle strength. It can assist in weight maintenance, but again, we're not seeing those benefits in patients with lipedema. It also can improve insulin sensitivity, but insulin resistance is typically not a big problem with women with lipedema. But some benefits we are likely to see is going to see improved body composition. We'll see improved movement from body fat to muscle, which is an essential part of lipedema treatment. We want to protect muscle mass, which we know declines with lipedema, and we want to improve adipocyte function. And exercise will improve different types of fat cells that we have and decrease inflammation in the adipose cells. That type that is most beneficial, or what we call brown fat, which is a much more metabolically active fat, and physical activity increases that. And that is called a beiging of fat cells. So turning what are white blood cells, which are the bulk of the red blood, bulk of the fat cells in our body, and turning them into these brown fats, or beiging them towards brown fats, which has more metabolic activity, less inflammation. And that metabolic activity comes from the mitochondria, which is the powerhouse of the cells, that those become more populated in these adipose cells and are going to increase the calorie burn and also the metabolic function found in these adipose cells. So let's look at a case report of a 48-year-old female with lipedema types 3 and 4, stage 3, relates a past history of being obsessed with the scale, and she cycled on and off diets with extreme calorie restriction, sometimes combined with laxative use. And it's just always very interesting to see how many women with lipedema have really struggled with eating disorders in their lifetime. But in this case, this weight cycling is of particular concern, because when we lose weight, we often lose both muscle and fat. But when we regain weight, we're not gaining the same amount of muscle as we regain fat. So that weight cycling is associated with an increased risk of something called sarcopenia, which is a lack of muscle. That women with lipedema have a relative decrease in muscle strength and a progressive decline in physical endurance. And so patients with lipedema would really benefit from graded exercise program. And this has been shown in a number of studies. Also, when we're looking at patients and making recommendations for physical activity, we want to look at muscle strength. We want to look at posture and balance, and how a person walks or gait, or joint hypermobility, the impact of that on physical activity, and look at that to assess for limitations to physical activity. Many women with lipedema have osteoarthritis of the knees and hips, which are going to limit activity, and something called genu valgum, which is when you develop that knock-knee deformity as you change your gait due to increasing of the size of the thighs. So resistance training becomes very important. You want to look at low impact exercises, an exercise bike or walking or yoga, but I really like water-based exercise, because water-based exercise has the benefit of both the hydrostatic pressure that is created, that's going to improve lymphatic return, that is going to reduce edema in the legs, as well as weight that does not have the same level of gravitational stress on the joints. And that too helps to improve ability to engage in regular exercise. And then vibration plates or rebounding are two other things that can be very helpful for the treatment of lipedema and building physical activity in patients with lipedema. So now I want to move on to talk about these new agents, these GLP-1 and GIP receptor agonists in lipedema. So I want to start with looking at what happens in appetite regulation. So the way our body regulates appetite is not through conscious decision making. We may decide where we're going to go eat, but when we want to eat and how much we want to eat is really driven by hormonal regulators of appetite. And we have one key hunger hormone called ghrelin. It's made by the stomach, and it sends a signal to the brain to eat more. And so when you're hungry, your stomach growls because you're producing ghrelin, and it is sending that signal to the brain to eat more. When we do eat, our body has a whole bunch of mechanisms that send a satiety or fullness signal to the brain that help us to stop eating. And leptin, insulin, amylin, GLP-1, GIP, CCK, PYY are just a whole bunch of, and actually just a small number of the many appetite regulators. And when we eat, those appetite regulators go down or go up, and they send a signal to the brain saying we're full. So when we don't eat, we make more ghrelin to make us hungry. When we do eat, we make more of those other agents which make us feel full. Now, when we calorie restrict, those ghrelin levels go up and all those other agents go down. And that's what makes losing weight so difficult, because we're getting this signal to the brain to eat more. And that is the biggest challenge. But what I'm going to focus on are three agents. That's insulin, GLP-1, and GIP. So insulin, we know insulin plays an important role in the regulation of glucose, but it also plays an important role in synthesis and a key role in fat synthesis and breakdown. So insulin stimulates the formation of fat and blocks the breakdown of fat in the body. So when we eat foods that are higher in carbohydrates or sugar, that's going to stimulate insulin, which in turn shuts down fat breakdown and promotes fat storage. And then insulin also has some effect on decreasing our appetite. But that's a key thing, and I think an important part in lipedema, because I don't find insulin resistance in women with lipedema. So what does that mean? That means that insulin is going to be more effective in women with lipedema, meaning it's going to be more effective at promoting fat storage and inhibiting fat breakdown. And this is why we think low carbohydrate diets are beneficial in women with lipedema. So the other category is something called incretins, and this is the GLP-1, which is glucagon-like peptide 1 receptor agonists. And there's two agents in this category that are approved for obesity: liraglutide, sold as Saxenda, and semaglutide, sold as Wegovy, also as Ozempic for diabetes. And there's also the glucose-dependent insulinotropic peptide receptor agonist, or GIP. And there is an agent that's a combination of these two that is just recently approved for obesity just a few weeks ago, called tirzepatide, or Zepbound. And so we'll go through what do these things do. But let me start with a case: a 50-year-old female with lipedema whose maximum weight was 318. She lost 88 pounds after a Roux-en-Y surgery in 2019 and followed a low carbohydrate diet, but she plateaued at 200 pounds with her buttocks, legs remaining large and painful, limiting her ambulation and ability to sit, which was part of her job. So the patient started semaglutide, which is one of the GLP-1 receptor agonists. And we know that these things have certain effects, particularly for diabetes, where they're going to improve how much insulin you make when you eat a meal, particularly one that's high in glucose. And then it also shuts down something called glucagon, which causes your liver to make glucose. So those are two things that really help with diabetes. But also on appetite side, it slows how fast your stomach empties, which can help you to feel full for a longer period of time, and also sends a signal to the brain to say that you're full. And so we call that essential satiety effect, that makes you not as hungry. And patients will say, I just don't feel like eating as much when they're taking these medications. So we see the role of these going well beyond their benefits for regulating blood sugar. As we mentioned, it works in the brain to decrease appetite. It actually may have a neuroprotective benefit for prevention of Alzheimer's, but that's something that's being studied. But more recently, it's gotten a lot of attention for protection of the heart, where the semaglutide was shown when treating patients with obesity to reduce heart disease by 20%, which is a pretty profound effect. And then we also see the effect on the fat cells, which is what we're interested in and talking about today. So what are some of those effects? And these are the lesser known effects of these agents, that they are going to increase that brown fat that I talked about. So the brown fat is that very metabolically active calorie burning fat that helps you burn calories and is a very healthy fat for you. It increases adiponectin, which is something else that's made by the fat cells that has an anti-inflammatory effect on the body and improves insulin sensitivity. The mitochondria, those powerhouses of the cell, work better with these agents, and this is thought to be due to decrease of an inflammatory agent called TNF-alpha that decreases inflammation in the fat cell, but in particular in the mitochondria. Another improvement in the fat cell or adipocyte is that it improves adipocyte differentiation. And I'll talk about how that is important in terms of whether we make more fat cells or larger fat cells. And then it decreases cravings and uncontrolled eating and helps you stick to a dietary regimen that you may be on for the treatment of lipedema. So the GIP agents have different effects. They also work on the pancreas to improve our insulin response, and they also work in the brain to decrease appetite. But they also increase fat formation in the adipose cell, which may seem contrary, but we'll talk about where that may be a benefit and not a loss. So these agents, as I mentioned, there's one agent available called tirzepatide, or Zepbound now approved for obesity. It was Mounjaro for diabetes. It also can produce a significant weight loss, more so than the Wegovy or the semaglutide, which showed about a 15% weight loss. This shows a 20% weight loss. We talked about those other effects. It works on the brain to increase satiety, but it also increases blood flow to the white blood cells. And one of the things we see with lipedema is that those tissues get a decrease in blood flow, which is thought to contribute to inflammation. So that improved blood flow can improve how much inflammation you're seeing in those fat cells, and that in turn helps them to function better. It also changes how we store fat. Instead of making the fat cells larger, we make more in number, and that has an anti-inflammatory effect. So we can see here that when we get overnutrition, when we're making fat cells, we can either make them bigger, and I'm gonna try to oops.
I'm trying to keep our heads out of the way.
Yep. So I'm gonna use a pointer here. So we can increase the size of fat cells, or we can increase the number of fat cells. And one of the challenges in lipedema, we tend to see what we call adipocyte hypertrophy, which we make more larger fat cells, which produce more fatty acids, which produce more inflammation and decrease insulin sensitivity. Whereas if we can make more of those cells rather than larger cells, then we can decrease inflammation in the body. And that's one of the areas where these may have a benefit in patients with lipedema. So with the lipedema fat, we typically are seeing larger cells, lower adiponectin levels, and impaired blood flow to those cells, which means that those are going to not work as well. They're going to be more inflamed, more tender, and bruise more easily. Whereas the GLP-1 is going to help improve that blood flow. It's going to increase those adiponectin levels, which reduces inflammation, and it's going to help those fat cells work better. So you're going to make more of the cells that are less inflammatory, and they're going to get better blood flow. So the good of these agents is that they do help reduce your calorie intake. They can help your fat cells to work better and help to decrease inflammation. And that really is important. Decreasing calorie intake is key, because when you are eating calories, your body has to do something with them. And this diagram sort of outlines what happens when we are consuming calories. And so normally when we're consuming calories, we burn a small amount of them right away. What we don't burn right away, we're going to store as glycogen, which is where we first go for energy when we're not eating, and the rest is stored in what we call subcutaneous adipose tissue and muscle. So that fat gets stored in the body. And this is really where we have a problem with lipedema, is that this subcutaneous fat, this fat underneath the skin, gets very large and overgrows. And so what we're trying to do is trying to avoid a large calorie load that has to be stored in fat. As with lipedema, when it goes to fat, it goes to the lipedema fat, but when you calorie restrict, it does not come off of that area. It tends to be a one-way street. So by taking these medications that decrease your appetite, that make you feel full with fewer calories, you have less of this calorie overload that overloads your fat cells. And that in turn helps keep you from increasing weight in those areas and helps your body to release the weight in that area. So we decrease inflammation by improving blood flow. With lipedema, we're going to see less adiponectin and larger blood cells, which causes inflammation. With these agents, we're going to see more adiponectin, which is going to be anti-inflammatory. We are going to see better formation of new fat cells rather than larger fat cells, and we're going to see better blood flow to them, and all that reduces inflammation. So what's the downside of these? Well, they're very effective at decreasing your caloric intake, and so we have to worry about calorie restriction. Now the paradigm shift that happens here is we're shifting from the idea that we need to limit our calories to now we have to get a minimum number of calories, and we need to get healthy calories in. When you're greatly cutting your calories, then the quality of the calories become very important. So we have to make sure we get enough protein in the diet, that you don't get protein malnourished. And that's very easy to do. And if you have lipedema and you're already at risk for losing muscle mass and you restrict protein in your diet, you're going to lose muscle. And that is a complication that you don't want to have. Patients with these medications have difficulty tolerating fat. So you can have some fat in the diet, but if you start eating fried foods or highly fatty foods, it can make you feel very sick to your stomach. People who have overly restricted eating patterns or a history of that sometimes can resurrect those feelings, and we want to be careful to avoid any kind of regenerating any kind of eating disorders. And then some general side effects. Heartburn can occur more commonly, or gastroesophageal reflux. And that's in part related to slowing of the emptying of the stomach, which can lead to more reflux issues. Patients complain of bloating and bowel dysfunction, either diarrhea or constipation, and there's a rare complication of pancreatitis or inflammation of the pancreas. So some of the benefits that we see with these in lipedema: they're very effective for reducing generalized obesity, helping you adhere to any dietary plan that you're following, whether that be an anti-inflammatory diet, a Mediterranean diet, or a low carbohydrate diet. It improves how our fat cells work. It decreases inflammation of the body. And many patients say their legs feel better on these agents. And that's what I really look for, is symptomatic improvement. But we have to be careful of the risks of malnutrition, of triggering side effects, and also the expectation that we're going to shrink the lipedema tissue a lot. I don't really see that as much. And so our patient lost an additional 15 pounds on the semaglutide, got down to 185, but she was being measured regularly by her physical therapist and didn't see any change in leg size, but her leg pain was better once she got to the 1.7 milligram dose of semaglutide. So we see symptomatic improvement. In this patient, we didn't see a change in leg size. We can see changes in leg size, but again, I don't want to create that expectation that it's going to resolve it. Just a little bit of a comment about bariatric surgery in patients with lipedema. This is a common area of question. So I'm going to start with another case of a 41-year-old female who had disproportionate lower body weight, starting at puberty, becoming markedly worse with each of her 3 pregnancies. Multiple diets resulted in limited weight loss, and she got up to 320 pounds. She underwent a sleeve gastrectomy. So this is just the different types of bariatric surgery that can be done. The laparoscopic adjustable band is where you put a band around the top of the stomach. Not really done anymore, not terribly effective, has a lot of long-term complications. Roux-en-Y gastric bypass is where you're going to remove a large portion of the stomach and then bypass that stomach. You don't remove it, you leave it, but you disconnect it from the you disconnect the top part of the stomach and attach it to the small intestine, a little bit down from where the stomach is, and that is going to bypass the stomach, and that decreases your calorie absorption. We'll talk about some of the other effects that has. There's the vertical sleeve gastrectomy or sleeve or sleeve gastrectomy, it's sometimes called, where that's basically you're taking out the bulk of the stomach and leaving a tube about the size of a banana left behind. And then the biliopancreatic diversion with duodenal switch, that's a sleeve gastrectomy and a gastric bypass combined. And that has some of the greater effects, and there's some variations on that as well. We often thought of bariatric surgery as just making the stomach smaller and making it harder to absorb nutrients. But actually, the effect of bariatric surgery is really metabolic. In fact, that's why they call it now both metabolic and bariatric surgery. When you take out a large portion of the stomach, you make less of that hunger hormone, ghrelin, which was made by the stomach. When you shorten the distance from the mouth to the small intestine, which is what the gastric bypass does, you make more of these agents that make you feel full that are made in the small intestine. So we see these immediate metabolic effects that greatly decrease hunger and improve some of the metabolic changes, like we see immediate improvements in diabetes, where patients can come off of insulin right after surgery. So these are really the key benefits that we see with bariatric surgery. We also see changes in the fat cells. So we see less of this overgrowth of fat cells or over-enlargement of fat cells or adipocyte hypertrophy. We see a decrease in the fat around the internal organs of the body. We see improvements in metabolic function. So your diabetes improves, your cholesterol and other lipid parameters improve. You see fatty liver improvement. All these get better with bariatric surgery, and you see an increase in that metabolically active brown fat. So here is Jenna before her bariatric surgery at 320 pounds. Here she is after bariatric surgery. So you can see she lost a tremendous amount of weight, and she even lost some weight in her legs. But in the end, what you still see is a large amount of lipedema type tissue around her arm, around her leg, around her thigh. You can still see cuffing at the ankle. You see this typical fat padding that occurs around the elbow. And so she had significant improvement in weight, but still lipedema symptoms improved. She then had a divorce, a stressful job, and a motor vehicle accident, which limited her activity. And she gained 50 pounds, which caused her legs to become much larger and painful again. And so this is one of the challenges that we see. So what does the data say about lipedema and with bariatric surgery? It doesn't say much, because there really is only a handful of case series or case reports, some showing benefit, some showing not. And so I think the jury is still out on that. So to summarize, bariatric surgery, GLP-1 receptor agonists, GIP receptor agonists are very effective for generalized obesity. They're very effective at reducing that unhealthy, metabolically active fat around the internal organs of the body that cause the problems like diabetes, hypertension, and cholesterol issues. They can improve how our fat cells work. But patients with lipedema are more likely to have more of a, what we call android fat, which is sort of that central weight. If we kind of make a U shape from the waist up, that's where we see it. We see it in the face, in the neck, in the chest, back, and abdomen, but we're not seeing so much in the arms and legs. It can cause some symptomatic improvement, but patients with lipedema shouldn't expect resolution of lipedema with these agents. And really, we're at the beginning of looking at these things, and more research is needed to look at the effects of bariatric surgery and these medications on lipedema.
Wow, thank you. That was wonderful. I Yeah, I've had some experience too, similar kinds of experience where it has helped my patients with lipedema, especially those who have concomitant obesity, usually, BMIs 35, 45, etc. And that's the thing is both with these GLP agonists as well as with bariatric surgery. And I think it's really important that there is no cure for lipedema, and of course surgery can help, but it's just one more tool, so it's these agents and treating the obesity can be so critically important for our patients with lipedema. Um,
And one of the things that we see is after lipedema surgery that it can come back, right? And it can come back if you're not following those dietary guidelines that are key for preventing that recurrence. And this is also where medication can make it easier to follow those diets, because when you take away that fat and you try to calorie restrict, you are going to feel hungry, and the medications can make it easier to offset that feeling.
yeah, so I mean, what we have figured, I mean, we figured this out that if we really treat it comprehensively with all that, we're going to have the best results. And it's you can't and it really you're the the best results are going to be those. And so I insist on that. I insist on dietary um modification for my patients before surgery, because I feel like they um that's when they're really going to buy into it and really see the benefits. And so they shouldn't just approach this, because of course, I mean, surgery is very effective, but it's just one tool, and it has to be part of a more comprehensive package.
Yes, I think I would agree with that. That and what I often find is that even if the weight doesn't change a lot with dietary intervention, for many women, their legs feel better. And
Yeah.
they'll see a difference that if they're consuming more of those refined carbohydrates and sugars, their legs feel heavier, they feel worse, they're more painful. And that all makes sense because of in part because of its effect on insulin. That insulin's overloading, taking that high insulin level is going to push more fat into cells that are already overloaded and make them more inflamed and feel worse.
Dr. Pennings, thank you so much. I really appreciate your taking the time to share this. This is going to help so many ladies, and I I really appreciate your dedication to oh, the lipedema ladies and our overall health patients with obesity. So. Uh, Thank you so much. I'm gonna so we're gonna go ahead and if anybody would like to leave questions or comments, feel free, and I'm gonna stop the recording now. Thank you.
Take care.